Welcome to this PCR webinar on how to minimize paravalvular leak in patient undergoing transcatheter aortic valve implantation. My name is Lars Sandergaard. I'm an interventional cardiologist based in Copenhagen, Denmark. It's my pleasure to be joined by two good friends from the US, Asim Latib, who's an interventional cardiologist from New York, and Michael Reardon from Houston in Texas. Michael is a cardiac surgeon, but also doing transcatheter-based interventions. So the learning objectives for today is going to be to learn how paravalvular leak may impact the clinical outcome for your patient undergoing transcatheter valve aortic valve implantation, and also to discuss a novel sealing technology in a next-generation transcatheter heart valve, and to learn how to reduce paravalvular leak by optimizing procedural steps. The webinar will be based on a recorded case, and we're going to break several times to discuss how to handle this patient. So let's start with the case presentation. So if we can start the case now, please.
So welcome to Copenhagen. I'm here with my colleague Ole de Backer, and before we go to the case, Ole, maybe you can give a short presentation of the case we're going to treat today.
Yep. Sure. Okay, so let's go to the slides. So this is a TAVI case with the new Navitar valve from Abbott. So the case we selected for today is a 77-year-old female. Normal body size, I would say. She is known in her medical history with arterial hypertension and atrial fibrillation, and now she presents with severe symptomatic aortic valve stenosis, dyspnea, NIA class 3, no angina. So on the transthoracic echo, she presents with a left ventricular ejection fraction of 30 to 35%, AVA of 0.8 square centimeter. So on the rest echo, we measure a peak and a mean transvalvular gradient of 54 millimeters mercury and 31 millimeters mercury as a mean. However, there is a good left ventricular contractile reserve, so she also underwent a dopamine stress echo, and there the gradients clearly went up to 71 and 44 millimeters mercury. So this is clearly an indication for treatment. So on the coronary angio, there's no significant stenosis. And on the ECG, there is, as said, the atrial fibrillation and a QRS of 166 milliseconds with a left bundle branch block pattern. Her labs, hemoglobin, rather, unspecial, so 11.2 grams per deciliter, well-preserved renal function, and in general, an STS score of 3.3%. So then if we dive into the CT analysis, so of course the most important to start with is the aortic valve or the aortic annulus. There we measure an annulus perimeter of 80.5 millimeter, or a perimeter derived mean diameter of 25.6 millimeter. You also see a discrete calcification of that annulus level, and then of course we also measure into the LVOT 2 to 3 millimeters below the annulus, and these are very similar measurements. So if we go to the next slide, we also measure of course the coronary height. Left main a tiny bit lower, 11.5 millimeter, but still safe for this for sure for this platform we're going to use, and then the right coronary artery at 16 millimeter. Then the sinus of Valsalva, of course, is also of interest to measure, so 29 by 32, and then you see here the moderate to severe leaflet calcification. There is good calcification on all three leaflets, matching with her severe aortic valve stenosis. Next. And then aortic root angulation is looks good, 45 degrees. ST junction, there is clearly calcification there, and ST junction diameter is 24 by 27 millimeter. And then if we look to the aortic arch here, I have to say that the aortic arch has a pretty sharp angulated. So this can be a challenge for crossing the arch. And then, of course, we are also very much interested in the cerebral vessels because we are going to use cerebral embolic protection. So you see the truncus brachiocephalic, we measure the diameter there, and we already have a look on the left carotid artery to see how much distance there is between the truncus brachiocephalic and the left carotid artery. So next. And then the access, this looks pretty good. There is some only mild calcification. There is good luminal diameters of above 7 millimeters. So the plan for this case is a TAVI case in local anesthesia only. Procile vascular closure device, Sentinel cerebral embolic protection device, as said, pre-dilatation matched to the minimum diameter of the annulus of a 21 millimeter balloon, and then the new Navitar valve with this active Naviseal cuff on the outside, and a 29 millimeter size.
So, Mike, this 77-year-old lady with severe aortic stenosis, you can offer this patient both surgical and transcatheter valve replacement. What is your thought? Which therapy should she be offered?
Well, I think, Laura, she has low flow, low gradient, even though she augments. And we know in surgery that raises your surgical risk. If she had not augmented, it would have tripled her surgical risk. But she's going to be a higher risk patient. And she's certainly at the age that we saw in the low risk trials, where we saw a benefit to a transcatheter valve. So in my institution, over 70, you'd be offered a transcatheter valve as long as your anatomy was appropriate for a transfemoral TAVI. So we'd agree with your assessment on this lady.
Yeah. Asim, you saw this presentation here. If you're going for a transcatheter aortic valve implantation, any specific consideration you're going to have for this specific patient?
Yeah, absolutely. So I think, there are a couple of things in this patient that jump out, and I think I go back again to what Michael just said, is that you want to have a really good result in this patient. So you want the patient to be a good candidate for transfemoral TAVI, which I believe the patient is. So things that I take into account in this patient is the low ejection fraction. I know there's some contractile reserve, but that can make it challenging at times, particularly if you have to do rapid pacing. Sometimes patients who have low ejection fractions don't recover well from a long rapid pacing run. That's the one consideration I have. When you look at the aortic anatomy, I think, the annulus size, I think you can get good oversizing with a self-expandable valve. The coronaries are fine, big sinuses. I am a little worried about that aortic angulation, and it may sway me as far as my choice of delivery system, because you can run into a little bit of trouble with a stiff delivery system, trying to get around that aortic arch. Okay? I think once you're around the arch and you're at the valve, I think things will be fine, but you have to be careful not to scrape the aorta or increase the patient's risk of stroke. I'm really glad you're going to be using cerebral protection. And then the last thing, I'll take into account, which is kind of more long-term, is the patient has left bundle branch block. So depending on how wide this QRS is afterwards, this may be a patient who, if there's not a lot of improvement in LV ejection fraction, may need resynchronization in the future.
So you said, as just to summarize, there's an acute angulation in the aortic arch. So we should probably look for a system which is flexible to reduce the risk of vascular complication. Patient have pre-existing left bundle branch block, and thereby also a high risk of having a complete AV block during a TAVI procedure. So maybe a valve which also have a lower rate of a pacemaker after valve implantation. We're going to discuss paravalvular leak today. Do you think this patient would both be a specific risk for having paravalvular leak, and also if the patient have a certain degree that's going to impact the outcome for the patient?
Well, I think, Lars, it's very clear that those that have poor ejection fractions do not handle aortic insufficiency well, no matter how it hits them. And so for the lower the gradient, the worse the ventricular function, the more important it is to to just trace paravalvular leak. So I would agree with you that paravalvular leak is important. It's important in all patients, but it becomes more important as your ventricular function goes down, because your heart ability to compensate will decrease.
Yeah, absolutely. I think in patients with low ejection fractions, we really want to give them the lowest possible gradients, so really good hemodynamics, and we don't want to leave them with PVL. I mean, that's the patient who's not going to do well. The patient who's already, his EF is down, LV is a little bit dilated. That's the patient you treat the aortic valve, and if you leave them with PVL, they don't get the benefit from treating the AS. So I think you really want to choose a valve that is going to give you as good a sealing at the annular level as possible.
And I would second the hemodynamics are so important in these people with low gradients. In surgery, we used to see these people that would come in with a relatively low gradient, and a surgeon would put in a valve that was too small and barely improve the gradient. And then they'd come out on all sorts of inotropes and then get into trouble. And the problem was they didn't need inotropes. What they needed was an appropriate size valve. And having a self-expanding valve that's going to give you the hemodynamics you need becomes crucially important in these people that have a lower gradients and lower ejection fractions.
So Mike, self-expanding technology is giving the largest opening area and the lowest grade. And we used to say that this is most likely if you use valves with a supra and a leaflet position. Is that true, or can it also happen with valves with internal leaflet position?
Well, it clearly happens with it, because you see with this particular intraannular valve, the hemodynamics seem to match that of the supraannular self-expanding valve. And I think some of this, Lars, may well be how these valves sit in the LV outflow tract and organize laminar flow, as opposed to surgical valves, which tend to have a fairly distinct cutoff and even tend to narrow LVOT some as we sew the valve in. So I do think some of it has to do with transcatheter valve design as well as opening and where the valve is placed.
Yeah. Okay. So maybe we should go back to the case and see the start of it.
So before we start this case, let's just introduce everyone. My name is Lars Sondergaard. I'm an interventional cardiologist. I'm here with my colleague Ole de Bager and our fellow Wilhelms from Lithuania. So what we have done so far is that we have on the contralateral side put a 6 French sheet into the femoral artery, which is going to be used for the pigtail catheter in the non-coronary cusp. We got a 7 French sheet in the vein, which we're going to use a short guide wire to do LV pacing here, but also as a possibility to give fluids or drugs during the procedure if needed. And then we have a 6 French sheet in the right radial artery, which is going to be used for cerebral embolic protection with a sentinel device. So next thing is to puncture here in the right groin, the ipsilateral side, to introduce the delivery system a little bit later on. So I already put some local anesthesia here, and we can use ultrasound guidance here to make sure that we're going to puncture in a calcium-free spot of the vessel here. So I will just, and we see we have in the middle of the vessel here at again as a place with no calcium, so we have a better chance that the closure device is going to work. I'll give you the needle, Ole. And then we're going to use the next generation of the ProGlide. This is called the ProStyle, and maybe you can say a few words about this iteration, Ole.
Yes, so compared to it's rather similar for use for people being used to the ProGlide, but on this ProStyle, I would say there are a few new iterations. First of all, there's an extra measurement tool on this shaft, so which gives you an idea of the skin to artery distance, and this is also handy afterwards if you have to do the pushing on the knot.
The forceps.
Yeah, the forceps. Yeah. Secondly, there is the needles have been reinforced, so they less easy deviate on a little bit of calcium. Third, I would say this kind of tool to cut your suture has been increased a bit in height, so it's easier to catch your suture, to cut the suture. And then lastly, okay, let's remove, and in the meantime, it has become a little bit even more hydrophilic and easier to introduce. Yeah.
So again, we're going to use 2 ProStyle devices here.
Okay, bleed back. And then we're gonna shoot the needle. Yep. So what Lars also did is he torqued actually a tiny bit less, not the classical as we talked about 10 and 2 o'clock, but more an 11 and 1 o'clock torque. And now the second suture is in line, pre-closure. Now we take J-wire. And then we're going to go with a 12 French. Okay.
Yep.
Yep. Okay.
Smaller sheet coming in here over the standard guide wire. Now we are going to exchange for a 14 French sheet, which is equivalent to the diameter of the Effectsnap delivery system. And to get the 14 French sheet in, we're going to use a stiffer guide wire. This is an Amplatzer super stiff wire.
Okay. Clean the wire.
Press a little bit.
Yes. So this is a just a random classical 14 French. This is a 14 French cook sheet.
Yeah. So it's actually making the delivery system the smallest on the market for TAVI. So it's 14 and 15 French equivalent size. So push that up here, and we can take
the AL1
dial up.
Like straight wire.
And then next, of course, will be to try to cross
the
valve here.
Okay, I'll zoom a little bit in. And
I need a straight guide wire.
Yeah, it's coming. So our first choice is always typically an AL1, I would say. Only if the anatomy, we know that the aortic root is really large dimensions, then we would go for an AL2. But otherwise, we go for the AL1 catheter and a straight wire. So now Lars crossed nicely, and we always kind of exchange to a pigtail. Yeah, okay. Table was just a little bit, okay. Good. So now this is an exchange wire. We're going to change for a pigtail. Yes.
And again, we use an REO projection here to elongate the left ventricle to have a better understanding how the pigtail is sitting in the apex.
Mm-hmm.
So I'll do some hemodynamics, and maybe you can explain what we can use those to. Again, remember this was a patient with low flow, low gradient.
Mm-hmm. Exactly. So what we are mostly interested in before TAVI also here, so we see there is a gradient, and then we look mostly to the end diastolic pressures also. So in the LV, the end diastolic pressure is here around 16, and then in the aorta, it's 74. So we look to these end diastolic pressures and the separation between these two curves end diastolically to compare before and after TAVI to have some additional assessment of PVL or not.
But I'll just put this dilator into the 7 French sheet in the vein here with a short guide wire.
Yes, so Lars has just introduced this short, kind of that's the wire who comes in the package with the sheet and goes intravascularly. One end of the crocodiles, electrodes goes on there, and then the other one will go, of course, on the stiff guide wire. Okay. This is the Safari extra small. Let's be careful we don't pull on the. Yep. Okay. So there are two advantages, I would say, on having the pigtail in the ventricle. First, you can do your hemodynamics. That's one thing. And secondly, you can optimize this position. You don't have to come straight with that stiff wire out of your AL1. So in a situation like this, it's in a way safer, I would say. Less perforation, LV perforation risk. Okay. So Safari is in place. Everything is in place. So then we can go for the balloon, I think. So it's even tiny bit smaller than the minimum diameter in the LVOT. LVOT was the minimum diameter was 21.4, so we go for that 21 in order to avoid any damage on the conduction system.
It's actually our routine here now for pre-dilatation. If you want to do a pre-dilatation, we often only use a balloon which is not exceeding the minor axis of the aortic annulus.
Yeah.
And again, this is of course the balance between having any annulus rupture, severe aortic regurgitation on one hand, and on the other hand to open up the aortic valve for better expansion of the stent frame. So you can go back here to, hello, just make sure. So the balloon we're going to use is a true balloon from BART. It's a non-compliant balloon, and I think some of the advantages is that it's very fast to inflate and to deflate, and it's going to take you to the nominal diameter. You cannot really overexpand it, so you cannot go further than 21 millimeter here. As we said before, we're going to pace what we call LV pacing. We're going to pace on the stiff guide wire. One crocodile electrode here is on the guide wire down here, and the other one in the short guide wire, on the short guide wire in the femoral vein. Of course, you need to have some kind of isolation on it, a balloon catheter, a delivery catheter, or a standard catheter. Otherwise, it's not going to work. So let's say that the patient is going to develop complete heart block during balloon dilatation or valve implantation. We have to put a needle in here, move the crocodile to the needle, and insert an RV pace lead through the catheter here. But let's see how this is going to work. So even if you can pace for us maybe 180, pressure's down, we're going up with the balloon. We come down with the balloon, stop pacing. What's here?
Get this one temporarily.
Oops.
Yeah. All right.
Okay. And again, we're going to just check that there's no conductance abnormality, so we can remove this.
Okay, I'll go live. Yep.
So next will be to, of course, exchange the 14 French sheet in the right groin with the Effectsnap delivery system.
So Asim, next will be to put the valve in. It's going to be a Navitar valve, the next generation portico valve with the new delivery system, the Effectsnap system. Maybe you can just explain how this actually is designed and what's the difference between the first generation portico valve.
Yeah, with pleasure. So let me just show you some slides and take you through some of the differences between the Navitar and essentially the first generation portico. So this truly is, I think, what Abbott have done very well. They really jumped a few steps ahead. So, usually as an iteration from first to second to third. I mean, I think they've jumped from first to a third generation valve, a modern generation valve. They've used the same stent design, but made some important changes. So you remember that, that if you look at the Navitar valve, it's got this large cell design to minimize coronary obstruction. The upper outflow cells are curved to reduce the risk of injury to the aortic wall. It has an inner Naviseal cuff that's made out of fabric material to kind of maintain a low profile. What's been optimized is the radial force, especially in the lower part of the valve and the inflow, for better expansion, anchoring, stability, and sealing. And I think the biggest difference, and the part I'm so excited about, and I'm sure Mike too, is this outer Naviseal cuff. This is really, a sealing area and sealing cuff that I think is really going to minimize PVL, even get rid of it. It's more than just having a pericardium on the outside. This is kind of, really a true cuff that during diastole is going to stop regurgitation in PVL. And I'm really excited to see how, this case is going to turn out. And as we see more data from Michael on the results for this. So just to very compare what Navitar is compared to portico, they look very similar, but there's some important changes, right? The cells are more curved, the aortic cells. The inner cuff has been changed from porcine to fabric to maintain really a low profile. And you now have this sort of next generation exterior cuff to reduce paravalvular leak. And also, if you look at the bottom part of the valve, you can see how the landing zone, is much smoother. It's the cells are covered almost down till the end. And I think this is also going to help to mitigate particularly for an intraannular valve PVL. An important change is really how the radial force has been improved. I don't have on this curve what the first generation is, but these curves have been moved upwards compared to the first generation Portico. So really giving better radial force and more consistent radial force across the sizes. As you see with self-expandable valves, the more you oversize, the more radial force you have. So remember, there are 4 sizes now from 23, 25, 27, 29. And really you can cover an annular diameter, mean annular diameter from 19 to 27 with these 4 sizes. So as we treat younger and younger patients, it becomes very important as well to have good hemodynamics. You mentioned earlier, Lars, this is an intraannular valve, and whether there are any concerns about hemodynamics, about intraannular versus supraannular. I think we've all been excited to see this kind of data where you see single-digit gradients for an intraannular valve, and I think a lot of it has to do with the valve design. And also the improved, I think, radial force. So you see large valve areas, 2 here in this study that you published last, and single-digit gradients. And I think particularly in our patient who has a low ejection fraction, this is going to be impactful. But really in all our patients, particularly those with longer life expectancy, this is really one of the important parts we care about. The other important part we care about in younger patients and those with longer life expectancy is coronary access. And I think here what's useful is this large stent cell diameter, which really, if you look at the size of those cells, they can fit 14 French to 21 French catheter. So hopefully with our 5 and 6 French catheters, we can easily cannulate the coronaries with this valve design. Here you can see an example of the right and left coronary being cannulated after Portico implantation. And I think as we'll learn during the session, using commissural alignment will also further improve that. The valve is mounted on a modern delivery system, the FlexNav. Many of you have used the FlexNav with the older generation valve, but now the Navitar is with the FlexNav. So you do get a lot of advantages from the system. I think the first is stability and accuracy on implantation. This is, as Lars mentioned, probably the lowest profile delivery system out there. You need really a 5 millimeter artery for the smaller valve sizes, up to 5.5 for the larger valve. I think a major advantage, particularly as we will hopefully see in this case, remember how angulated that aorta is? So I'm really keen to see how on a Safari wire, which is not a very stiff wire, but a very safe wire, how this valve is going to track around the anatomy to hopefully give us greater deliverability. I think also now with the FlexNav and the way it's been designed, we have more stable deployment, allowing us to implant the valve more accurately. And it's recapturable and repositionable and retrievable up to a point, which we'll see now in the live case. So I'm going to stop there. That hopefully gives the audience a summary of this next generation Portico valve with the FlexNav delivery system.
That's great, Asim. And I can, if you just add one thing, there's a study ongoing now with a 5th size valve, the Titan valve, which is going to cover annular sizes up to 30 millimeter valve. So it's going to cover the entire spectrum of aortic annular sizes. So, and hopefully that's going to be approved soon. So let's go back to the case and see how it's actually used, this FlexNav system and the Navitar valve.
And again, very atraumatic nose cone here. We have the capsule here with the valve inside. We have the integrated sheet. It's very hydrophilic, so it's easy to introduce. And then you have this stability layer here, which is going to mitigate how much is going to dive towards the LV during deployment. So we're going in here, yeah, and now the integrated sheet is all the way in, so I can reconnect to the hemodynamics. And again, since it's a quite acute angulation, let's go quite a lot of LAO to make sure that we can actually see how it's traveling around. So let's see, again, it's a challenging anatomy, but this is a flexible system. So so let's try here, and you can give me a little bit of railing. 1, 2, 3.
Yes, I'm doing
1, 2, 3.
Yeah,
1, 2, 3.
Yeah, and then
you see that it make that small kink, which often facilitate to take this quite tortuous anatomy without any major risk of vascular complications. So going to here, and
you go to a cusp overlap. It's just called LAO something here.
Yeah.
Like that.
So again, we're working here in a cusp overlap view. This means that the right and the left coronary cusp is overlapping. As we see here, the advantage is that you're going to have often no parallax in your delivery system and still have the 3 aortic cusp aligned, which is of course going to give you a better understanding how deep you are with your implant. Furthermore, you're going to elongate the left ventricular alpha tract, so you have a more one-to-one understanding on your depth of your implant. What we could try, Ole, if you can see, we can try to see we can make a commissural alignment here. So we can try to rotate, and looking at the posts at the top here, in the middle of the frame, we want to see if we can isolate. Just give me 1 second here. We can maybe increase. So let's try to rotate a little bit here on the delivery system and see if you can have one of the posts on the far right hand side of the screen, and
quite a bit now. Yeah, I think we have kind of one is more or less isolated.
Yeah, so again, in the middle of the stent frame, it looks like one is isolated on the right-hand side of the screen, and the 2 others overlapping on the left-hand side of the screen. This should hopefully going to give us commissural alignment afterwards, which is important both to be able to access the coronary arteries, but probably also for the durability of these valves. So before we start, just let's do a first injection, confirm that we have the pigtail in the bottom of the non-coronary cusp. I think we got that.
Yeah.
And I think you see we want to be in somewhere in between the bottom or the inflow part of the stent frame and this first intersection where we are now. So I think that's going to position the valve about 3 mm below the aortic annulus, which is the target here. So I'm just doing slowly counterclockwise rotation here on the handle. You see that radiopac ring at the end of the capsule is now moving up. It's at the inflow part of the stent frame. It's now halfway up to the first intersection. And here at the first intersection is the position where it starts to flare out. I think it's sitting very stable here, and we're not doing any pacing. It's an intra-annular position of the leaflet, so often you don't see any compromise on hemodynamics, which is of course also important in this case with a patient with severely impaired LV function, that you don't need to do rapid pacing or long time pacing here. So now we are up here at the stop button. I can just go a little bit more. And the important thing here is to roll back to now a classical LAO cranial projection and confirm that we actually have the implant below the left coronary cusp, which we got. So I think we're sitting here in a very nice position. I'll be very happy about this position.
Yep.
So what we can do now, Ole, is that you can take some tension off the guide wire.
I'll do that.
I'll go a little bit further up here. And as long as you have that radiopac ring at the end of the capsule below the metal part, you can actually still recapture if you want. So we're going to deploy here. I'm pulling the pigtail back, and we go slowly here at the last part here. And I see at least 2 of these tabs that are out. Maybe we also have the third one. I think we have the third one here on
looks like the third one
on the left-hand side. So I think we are released here. So we can now slowly come back with a nose cone.
And then only
leave
now,
the guide wire in the LV.
Slowly.
And coming around the aortic arch to the descending aorta, where we're going to close the capsule. And you can just show what you're doing now, Ole.
Yeah, this is also a new feature on the Effectsnap system, so it's really easy. We push these blue knobs on the sides, and then in one fluent movement we can recapture that nose cone, and we make sure not to oversheet. And then we take it out. And
also very important is the nose cone coming down to the sheet and not the sheet up to the nose cone. So it's a more atraumatic movement. I'll just compress.
Yep.
And we're going to reinsert the 14 French sheet, and then we can do our assessments and see if anything further is needed. So we reconnect to pressure line. And we put pixel into the LV.
Yep.
Get the pressure line here.
Yeah, wait a second.
So we see pressure is a little bit lower now than it was before. There's a good separation. We can try to make, we had 74 and 60
very nice
before.
separation now, actually.
So it's 8 and 34. But again, take into account that the pressure is a bit lower than it was start of the procedure. So let's do an angiogram here. And we can go back to that Cusp overlap view, which was, do we have its LAO 0, caudal 31.
Caudal 31, yeah.
And you see also we have, we have pretty good commissural alignment. If you look at the outflow part of the stent frame, you see you have one of the tabs position on the right hand side of the screen, and the two other one is almost overlapping on the non-coronary. It's not perfect, but it's close to be.
We have definitely avoided that one of the commissural posts is in front of the coronary.
Exactly, have severe commissural misalignment. So let's do an injection here.
Yeah.
And I think we have a very nice position.
Yes,
we are where we want to be, about those 3 millimeters below the aortic annulus. I don't see any paravalvular leak at all. And we have now done, I don't know, around 25 cases with this Navitar valve, and we haven't seen any patient having more than a mild PVL. And that's also aligned with what we saw at the first 120 cases presented at Euro PCR 2021.
Perfect.
So I think we complete this case. I mean, you saw that with this Navitar valve was a very smooth implantation, no need for pacemaker, no for pacing during the deployment. Hemodynamic was stable, no conductions abnormality, no paravalvular leak, and also, even though we had that quite acute angulation in the aortic arch, since the system can make that small kink, it will take those challenging anatomies. So I think we can conclude this.
I think especially also in this particular case with a low flow, low gradient, this patient really has an ejection fraction around, depending on echo to echo, from 25 to 35. You don't need any pacing, very hemodynamically stable during the entire valve deployment. That's also a big advantage.
Yeah. Okay, thank you.
Thank you.
So, Michael, we saw a very nice outcome here. We have some more robust data because this valve was investigated in the Portico NG trial, which actually led to CE-mark approval in May 2021. Maybe you can just show us a highlight of the outcome of this study.
Well, maybe before I do that, Lars, if I can just comment on your case. First of all, that was an excellent case. you made a comment about the spread between diastole and LV-EDP. Of course, your pre-measurement was done at a heart rate of 107 and the post was 64. I think if you paced them up, that would have disappeared. I think this was an absolutely stunning outcome. And I think that, you know, as somebody's been doing heart surgery for almost 40 years, the rapid advance in both the technology we have to use and our ability to use it, how we do it, such as the double cusp overlap, and your techniques for lining up the commissures, to me as a surgeon, have been really quite stunning. So I'm going to talk a little bit about the data we have out there. And the first data that we're going to talk about is for the Navitar valve is the Portico NG study. And it was a prospective, multi-center, global investigational study evaluating the safety and effectiveness of the Navitar current generation transcatheter aortic valve in patients with symptomatic severe stenosis and high or extreme surgical risk. I had the opportunity to run this trial with Professor Londegaard. And of course, this was a global study that included the US, Europe, and Australia. The subjects had symptomatic severe AS. They were enrolled in 19 different sites across the geography we mentioned. They had follow-up visits at discharge, 30 days, and annually going on for 5 years. Our primary endpoint was all-cause mortality at 30 days and moderate or greater PVL at 30 days. We also had some descriptive endpoints of VARC2 clinical events at 30 days, valve hemodynamics and PVL at discharge in 30 days, and changes in NYHA and 6-minute walk tests from baseline to 30 days. And I think as we move into lower risk younger patients, exercise capacity such as 6-minute walk is going to be increasingly important to us. These are the baseline characteristics. You can see they match high risk. They're almost 84 years of age, over 50% females, very small AVAs, very high mean gradients. Most of these people were in NYHA 3 or 4, so it's a pretty sick group, and a STS of 4, a little lower than we saw in the other high-risk trials. But for all of us running trials now, we know the STS is dropping, and it's going to continue to drop for a variety of reasons, not the least of which is as STS keeps getting recalculated, we're removing higher-risk patients from the group. Almost 6% had prior strokes, a quarter pre-op AFib, a quarter diabetes, a quarter kidney disease, and more than one frailty factor and over 80%. So a high-risk group of patients. If we look at the 30-day outcomes, there were no deaths at 30 days. This was presented by Professor Sondergaard at PCR, and we had very low rates of VARC2 events. We had no mortality, no cardiovascular mortality, 0.8% disabling stroke, 2.5% life-threatening bleeding, acute kidney injury 1.2%, and new pacemakers 15%. And here's kind of the money slide for this new valve. You saw the hemodynamics. Dr. Lateeb has already shown you this. We have EOAs of about 2 and mean gradients in single digits. This is going to become increasingly important as we move to lower patients that want to be physically active. If you're physically active, most of our echoes are done at rest, but at exercise, unless you get up to EOAs close to 2, you really can't increase your flow without increasing your gradient. And of course, this new generation valve, which has an external skirt, much like all these valves have added, but one of the interesting things about this skirt is it's only fixed at nodes so that it actually parachutes out and fills the gaps. We see nothing beyond mild paravalvular leak, and mild is only 20%, 80% is none to trace. So exceptionally good paravalvular leak rates. Now the US portion, this was the European portion, which was used for CE mark. The US portion of the trial is now complete. Lars and I should be seeing the data on this coming up in a month or so. We'll have our last patient who's 30 days during July, and then we'll do our data cleaning. We hope to bring that data to you this year. And of course, there's a new trial, the Vantage trial. Dr. Lateeb and I will be global principal investigators. We'll have regional principal investigators in the US, Europe, and Australia. And the primary endpoint of this will be all-cause mortality or disabling stroke through 12 months as is currently planned. All patients will be intermediate or low risk, and currently it's planned to be a 10-year follow-up study, as all the intermediate and low-risk trials are, realizing that longer follow-up becomes increasingly important as we move to younger and lower-risk patients. So I think, Lars, we have some already exceedingly good data on the Navitar that you've presented, and we're going to be creating some new data over the next couple of years with the Vantage study as we get that study up and running.
Yeah, I think it's certainly very encouraging data we have seen for this study here on this new valve, the Navitar valve. Before we start the discussion, because we have quite a number of questions for the attendees, I'm just going to show you a few slides on how to gain patient-specific commissural alignment using this Navitar valve. So we know that you can divide all transcatheter heart valve into 3 groups: those with a low stent frame and intra-annular leaflet position, those with a high stent frame with intra-annular leaflet position, such as the Navitar valve, and those with a high stent frame and supra-annular leaflet position, as the Evolut platform or the Accurate. And we know for the 2 first, after a TAVI procedure, it's often not that challenging to access the coronary arteries, but if you have supra-annular leaflet position, it may be challenging. And we saw this re-access trial just published about 6 months ago. It was 300 patients undergoing TAVI. All patients had cannulation of the left and the right coronary arteries just prior to valve implantation, and then repeated after valve implantation. And actually, in 23 patients, 7.7%, it was not possible to access both coronary arteries. And out of these 23 patients, actually 22 patients was treated with the Evolut platform. So for that platform was almost 20% of the patient where it was not possible to do it. Lower rate for the others. And one of the main reasons it's not possible is that you're going to have commissural misalignment. So when we implant this valve, it's going to be rotated randomly in the aortic annulus. So what we should try to gain is commissural alignment, to try to rotate it exactly the same way as a native valve is, same as the surgeons are doing when he's replacing these aortic valves with a bioprosthetic valve. And how can you do that? There's been a move from using a classical 3-cusp coplanar view, which is often with a C-arm in an LAO cranial projection, to now move the C-arm towards an REO caudal projection, which is defined as a left-right cusp overlap view. This is a projection you can determine on your pre-procedural CT scan. And the reason people are using this now is try to have a lower rate of conduction subabnormality. You have a better understanding how deep or how high are you with your implant in a cusp overlap view compared to a classical 3-cusp coplanar view. But this view actually also gives you a unique opportunity to have patient-specific commissural alignment. Because when you have this, as you can see here on the left-hand side, the C-arm is overlapping, looking at the right and the left cusp overlapping. So the commissures between those 2 cusps is pointing to the right of the fluoroscreen. So in this view, the only thing you need to do is to orientate one of the leaflet posts on your transcatheter heart valve on the far right of the fluoroscreen. So of course you need to know where are the leaflet posts located. And for the Navitar valve, you can see them in the middle of the stent frame. There's 3 posts visible on the stent frame, and they're actually positioned right under these 3 tabs in the outflow part. So as you come around the aortic arch, often in an LAO projection, you go into the ascending aorta and crossing the aortic valve, you change your C-arm angulation to a left-right cusp overlap view. And then again, you know that the commissure between these 2 cusps are located on the far right of the screen. So you just need to position one of the leaflet posts to the far right, whereas the 2 other ones should be overlapping on the left-hand side. And as you can see here in the middle of the frame, you see 1 post there and 2 other is overlapping. And this is an example how to do it. And if you don't see it, you have to do some rotation on your delivery system. It's actually very small movement. So if you do the calculation, you will see from having severe commissural misalignment with one of the leaflet posts in front of the coronary arteries to have perfect commissural alignment is only going to ask for 3 millimeter rotation of the delivery system. So very small. So when you do that, you just continue, you do the deployment, and afterwards, what you want to see again in a left-right cusp overlap view is one of the leaflet posts on the far right of the screen and the 2 other overlapping on the left-hand side of the screen. So I think maybe we can go back here. We have some questions, and maybe I can pass them on to you. There's a question maybe to you, Asim, here. What kind of guide wire are you using when you implant the valve? What kind of stiff guide wire?
Yeah, I think that's a good question. Because, and I'll say there's a lot of variability amongst operators and even amongst different countries. I used to use different guide wires for each valve once upon a time, and now I've just simplified it. I use Safari for every valve. I think it's reliable. I like the pre-shaped curve. It gives me the right amount of stiffness, and I think it's very safe. The only decision then I have to make is whether I'm going to use a small or extra small. And if it's a very hypertrophic small ventricle, I'll use an extra small. Otherwise, majority of cases, I use a small.
So there seems to be some difference between Europe and the US. Quite a few sites in the US use the Lundquist guide wire, where the Safari wire is common used in Europe. Does it matter whether you use one or the other guide wires?
So, I think for example, the core valve, there are a lot of operators here in the United States that believe that the Lundquist gives you more stability during the cusp overlap technique and trying to get a high implantation. But I honestly think it's more related to the operator and how you do it. And I think you have to use the safest guide wire possible. And I do believe that a pre-shaped wire is much safer than a Lundquist.
There's also a question about this pacing on the guide wire. Is any specific tools you need, and do you need to have a very high energy for pacing during that? I don't know who wants to answer that.
No, well, we do the same thing, Lars. We don't do it on balloon expandable because we don't want to lose capture. If we lose capture of this, it doesn't really matter. For those that haven't done it, you do have to take the insulation off your wire in the ventricle. So you have to take a knife and scrape it off. And we usually use a safety wire from our small sheath on the right around. I just take my positive lead and clip it to my 018 safety wire. You don't need to put a needle in the skin. You don't need to put another wire in. And it actually works really well. The one downside, as you mentioned, is if you get complete heart block, you have to put another pacer in because you have to have some insulation around that wire in the ventricle. So it's good to either have something in the neck or something in the groin if you're going to do that.
Yeah, I think Michael mentioned all the important parts. You also need to look at your pacemaker box. You need to be able to at least go up to at least about 20 millivolts or even more to get pacing off the wire. But it's a good technique to know. I mean, even for those of you who still want to put a pacemaker lead in, I think it's good to know how to do this. It can be useful in so many other procedures as well. So, when we do tricuspid procedures, for example, and we need to have a pacer in, that's what I do. I put one of these pre-shaped wires into the left ventricle so that I can pace because I don't want anything on the right side. But I agree with Michael. I try and avoid using pacing over the wire for balloon expandable valves. I just don't want to take the chance of losing pacing in the middle of an implantation.
There's also a question about this, which C-arm projection to use during valve implantation. And again, I think we all started out using a classical three-cusp coplanar view, which is often positioning your C-arm in an LAO cranial projection. How do you see that? Is it changing every institution, or is it just selecting institution who's going to this cusp overlap view?
Well, I'll say, Lars, we do all of our self-expanding in the double cusp overlap. I still do my balloon expandable in a coplanar, although there are implanters that do balloon expandable now in double cusp overlap also. And as you said, the big advantage is besides stretching out the LVOT, because the pacemaker rate with self-expanding is not intrinsic to the valve, it's how you implant the valve and where you implant the valve. And so we're implanting them in a better position with a double cusp overlap, along with the fact that it usually takes 95% of the time to parallax out of the valve. So there's no other adjustments needed.
Yeah, I think that's the most important part, is the last part. For those, I have to admit, I was a later adopter to cusp overlap because I didn't feel my outcomes were really bad with the classical technique. But we all know those cases where you're in the three cusp view and your delivery system is just so out of plane to the annulus. And so you go more caudal, and then you completely lose having a coaxial view on the valve. And I think that's really, for me, the biggest advantage of the cusp overlap view has been the fact that I can now have my native valve and my transcatheter valve both coaxial. And that makes a real big difference in just having you better understand where you're going to end up. I mean, there may be people who still feel uncomfortable about being too high or being, at zero, and that's okay. I think using the cusp overlap just gives you a better idea of where the valve is going to be. So you can make better adjustments or better decisions about where your valve is.
Now, I will comment, Lars, that when you roll over to that LAO, like you do to look at the left, your non is now going to seem a lot higher, and you need to learn to ignore that. And if you ever do your 3-minso and roll over with a line across there, you'll see how it rolls up. That's not, your valve did not move up. It's just your imaging. But for people just starting to use the double cusp overlap, they often do an LAO, and now they think, oh no, I'm too high.
Yeah, so working in an LAO cusp overlap, you're actually not aiming to have a high position. You go for the same implant depth, but it's going to be the true implant depth. You often get fooled if you're in a tri-cusp. You think you're high, but you're actually sitting in a lower position. So it's all about trying to reducing the rate of conduction abnormality. And as we'd also discussed here, it's also a perfect view to go for patient-specific commissural alignment. So with this, we have started out the TAVI program in quite elderly patients with limited life expectancy. It's now going to move down to younger patients with longer life expectancy. We saw the recent American guidelines suggesting TAVI even down to patients at 65 years of age. So, Asim, what do you think we should expect from a transcatheter heart valve, which is used for patients with longer life expectancy? I think it's going to be different things than patients with limited life expectancy.
Yeah, I think the whole decision-making process has to change a little bit, right? So, when you look at a high-risk 85-year-old, it's all about just treating the aortic stenosis, right? Getting rid of the paravalvular leak. You don't want to give them a pacemaker, but you're essentially thinking about the fact you're probably only implanting one valve in that patient. The minute we go to patients who are younger, and I have to tell you, in the United States, the bar has moved. We have patients who are in their late 60s, early 70s, who come in saying, we want TAVI. And our first discussion, our heart team, is, yes, sure, we'll discuss, we'll consider you for TAVI, but you have to be a good candidate for TAVI long term. And for me, what does that mean? It means looking at the anatomy and being pretty sure I can have no PVL, zero PVL, or at least mild PVL in a small percentage of patients. I think so. My goal is much higher. I want to have single-digit pacemaker rates in those patients too, okay? And then I start thinking about other things, hemodynamics, and how will I give them good hemodynamics long-term? Very important is coronary access. And that's often a consideration we don't do in the 86-year-old who's getting one valve, right? And yeah, it's not just about, can I cannulate the coronaries when the patient comes back 3 years from now? But it also, we need to start thinking about what happens when the patient comes back 10 years from now and needs to have a TAVI and a TAVI, and then will I be able to have coronary access after that second procedure? So I think the bars really change. Of course, durability is important, but we need better ways to predict, okay, how the patient will do after their second valve, the TAVI and TAVI. And I think that's where valve selection becomes really important, and prosthesis selection, but also something you showed us really well today, Lars, which is patient-specific commissural alignment. Because I do believe that if you align the commissures better, when you do that TAVI and TAVI procedure, you're probably going to maintain coronary access in a better way, okay? And you're probably going to get better durability as well long-term.
So, Mike, when TAVI was launched almost 15 years ago, there was a lot, surgeons said this this therapy is going to be related with high rate of PVL, high rate of pacemaker. What's the durability of this valve? What about vascular complication? How do you see that has been changed during the years, both with how we as operators is executing the procedures, but also with the new iteration of valves? Are we there now? Can we offer a valve as good as the surgeons can do?
Well, I think we're very close to that, Lars. We used to be happy if we left without moderate PVL. Now, if it's more than trace in my lab, we feel like we've done something wrong. Our pacemaker rate is consistently in the single digits, no matter what valve we're using right now. And so far, the durability seems to be matching that of surgical valves. And whether surgeons like it or not, we are going to see younger patients coming in asking for TAVR. Because in Houston, Azim, I see people coming in their 50s wanting TAVR, and I'm often having to explain to them why they are so much younger than me. They might do better with surgery. So we're getting better, and the rate of change and improvement has been absolutely, for somebody that's done surgery for 4 decades, absolutely stunning. We're getting better devices. We're learning more about how to implant these valves. And I think with time, we're going to learn even more about the durability. And so unless there's surprising data in the low-risk 10-year data, this is going to be something that's just going to continue to increase.
Yeah, I agree. But I just think, I want to remind people that if you're going to start treating patients with longer life expectancy, the bar is really high. I mean, we have to, as those of us putting in transcatheter valves, aim to give surgical-like results to our patients. Otherwise, we do them a disservice, and surgery is not dead. There are many patients who still do very well with surgery, even in their 70s and 80s, because we can't give them a good result with a transcatheter valve.
So I think we, at the end of this webinar, we have discussed how actually to try to reduce or minimize paravalvular leak. This is one of the very important issues if you want to move forward with the TAVI procedures to patient at a younger age and with longer life expectancy in combination with the other factors we actually discussed. We have seen that this Navitar valve with the new outer active sealing cuff is probably top of the class now, with none of the patient having more than mild PVL and 80% of the patient have none-only trace. So I think that's really excellent outcome. I want to thank you, Azim and Mike, for participating in a good discussion and good presentation. For you who attended this webinar, I hope it was useful for you, and to Abbott who sponsored it. So, bye-bye.
Thank you. Bye-bye.